Greetings and welcome to this infectious disease series in Medicine Beyond the Horizons, where we'll discuss about the Enteric Fever. This is based on the paradigm shift of Enteric Fever treatment over the last few decades. So we'll discuss the Enteric Fever from introduction to the complete treatment guide. This is completely for educational purposes for physicians. This is Medicine Beyond the Horizons. Let's get started. So as we all know, the pathogen causing Enteric fever is Salmonella typhi or Salmonella paratyphi, of which Salmonella typhi is commoner than Salmonella paratyphi. So Salmonella paratyphi is also easier to treat than Salmonella typhi. So it is a gram-negative bacilli in the Enterobacteriaceae family. It is mainly transmitted by contaminated food and water. It is also the fake oral route. So risk factors are low socioeconomic status, poor sanitation, exposure to carriers. So it is said to be in a carrier state in case of cooks and in the gallbladder. So WHO 2021 estimates around 11 to 21 million cases annually with 1,61,000 deaths yearly due to Enteric fever. The true burden of the disease is yet to be estimated properly. It is underestimated. So we'll discuss about the clinical manifestations. It has a long incubation period, up to 1 to 2 weeks. So when a patient comes with fever for 5 to 7 days, so even food taken 2 weeks ago can be the reason for enteric fever now. So it hallmark is the high grade stepladder fever that is always described. So the patient usually presents around the day 5 to 6 of illness into the emergency with previously consulting a doctor, maybe in a clinic or no other OPD setup, where he would be prescribed a common antibiotic for which the fever was not resolved, and he came. The patient may have chills and rigor along with fever. There might be abdominal cramps, constipation or diarrhea, of which constipation is more common in second week than diarrhea. There may be dizziness, nausea, vomiting, headache. The headache can be intractable, severe headache, homocranial headache. And the patient may also have dry cough due to bronchitis and diaphragmatic irritation. So the signs are the commonly described sign is the relative bradycardia, also called the Fidget sign. There will be usually it is described as 10 beats per minute increase in the pulse rate for every 1 degree rise in temperature. But in cases of enteric fever, there may be relative bradycardia. There may be abdominal tenderness. There may be hepatosplenomegaly, which splenomegaly is more common than hepatosplenomegaly. There may be abdominal lymphadenopathy. Often, when you do a CT scan, there may be mesenteric lymph nodes prominence or mesenteric panniculitis. Or these are the features of enteric fever. There can also be ileocecal wall thickening due to Peyer's patches hypertrophy, often mistaken for inflammatory bowel disease. There can be rose spots in that 3 to 40% of the patients and often found in the second week. In case of Indian setup with dark skinned people, the rose spots may not be visible at all times. So mainly we need to consider the complications of enteric fever with high stakes of complication. This needs more care for treatment. So there may be perforation risk, hemorrhage. In case of cardiovascular system, it itself can cause myocarditis. It can cause shock in case of neurological manifestation, it can itself lead to encephalopathy. It can lead to meningitis. So, a fever patient with abdominal symptoms and headache, always rule out encephalopathy and enteric fever meningitis. In case of respiratory, it can itself cause pneumonia in rare scenarios. Uh, in case of hematological, it can precipitate DIC or leukopenia. The common hematological abnormality in case of enteric fever is the leukopenia and lymphocytosis with relative eosinopenia. The eosinophils can be almost zero, as described in the Boyd's textbook. So the diagnosis is the most standard gold standard diagnosis for enteric fever is the cultures. Blood culture, it is commonly done. The bone marrow culture is also done. Blood culture is almost 60 to 70% sensitive, whereas the bone marrow culture is 80% sensitive. So it is the isolation of Salmonella typhi from these sterile sites is the diagnostic for enteric fever. So almost always the blood culture Salmonella typhi is never a contaminant. So it is significant of infection and sepsis. So the most common method of isolation of bacteria is from the blood culture. Two sets of blood cultures taken should be taken 30 minutes apart from different sites. The Salmonella bacteria can grow if it is more preferable to take the sample at during the febrile period. Can detect loads of as low as 1 colony forming units per ml. It is influenced by the bacterial load and the volume drawn. So bone marrow culture has the highest sensitivity. It is less affected by the prior antibiotic use. Even if the patient is exposed to Ceftriaxone or Cefixime, you can use a bone marrow culture for isolating Salmonella. It's invasive but gold standard for difficult cases where you have the need to prove Salmonella. So you can also use other sites where stool culture can come positive for Salmonella, urine culture on rare scenarios, and bile culture. In case of chronic carrier shedding bile, you can do an endoscopy, collect the bile from the ample of water, and then culture it for Salmonella typhi isolation. All these have lower sensitivity than the blood or bone marrow culture. So nowadays, serological detection is upcoming, where we can use the Kaufman-Weiss classification system, detect specific antigens such as VI polysaccharide antigen, which is the prime antigen for virulence, O antigen or somatic O antigen, or flagellar H antigen also can be used for serological detection. It is widely used, but it lacks specificity. It is though it is highly sensitive. It only indicates the likelihood of infection, not confirmatory by themselves. So Felix Widal test, the outdated test that is yet performed in many hospitals or OPD settings, of which mostly avoid doing this Widal test. We have seen a lot of patients coming with a viral report of positivity in case of dengue fever or strep typhus or leptospirosis. There may be a lot of false positive, even with past infections, vaccinations, and some few people also do this test even in the first week. There will be no use of doing this test in the first week. So always do this test even if you're doing in the second week. The timeline for appearance of O antibodies is around day 6 to 8. In case of H antibodies, it is up to day 10 to 12. It is an agglutination test, basically detecting antibodies against the O and H antigens. It uses serial serum dilutions for detecting the antigens. It has a moderate sensitivity and specificity. There is a high cross-reactivity with other Enterobacteriaceae. Even an E. coli UTI can cause cross-reactivity with viral test. So, how to interpret Widal? It is of one use, there is fourfold rise in the parent serum. When you repeat a Widal test 2 weeks apart, if there is a fourfold rise in the dilutions on the serum, then consider it as significant. Otherwise, it is not used clinically nowadays. There are new modalities that have come up now. Typhidot IgM is one of the most commonly used tests nowadays in available setups. So, you can use IgM or IgG against the 50 kilodalton antigen present in the typhoid bacteria. It has an high sensitivity of 95% and a specificity of 75%. So IgM detects for acute infection and IgG detects past infection of more than even 2 years. So there is one more test called Typhidot IgM, which removes IgG to improve the specificity. So there is also a few other tests such as Tubex test and PCR testing. Tubex test is a very quick 2-minute inhibition assay. Detects anti-O9 antibodies. It has better sensitivity and specificity than Widal. It has an extensive evaluation pending. It is not yet used commercially in major hospitals. So PCR testing target is the flagellin FLIC antigen and the VI genes. It is highly specific. It is highly expensive also. It needs trained personnel and has very limited routine use. May come up in the near future. So advanced diagnostic and biomarkers, these are genomic diagnostics in research modalities where you can use RNA sequencing signature of 5 genes, that is STAT1, SLAM-F8, and PSME2, WARS, ALDH1A1. All these RNA sequencing signature genes can be used for diagnosis. It has a high sensitivity of around 97% and specificity of 88%, as these are upcoming in the near future. Can also use protein markers such as OMPA and PAC-C and H1E. These techniques are LCMS in vivo antigen capture detection assay, detects active infection in the lymphocyte supernatant. So there are also metabolomics, where there is altered iron and tryptophan metabolism in case of enteric fever infection. There is hepcidin upregulation, strongly linked to Salmonella typhi. These can differentiate typhoid versus paratyphoid. So there can be spectrometry can also be used for enteric fever diagnostic. The diagnostic cues are distinct plasma metabolite signatures distinguish enteric fever from healthy controls. It mainly uses the hepcidin upregulation and tryptophan pathway disruption. All these are research modalities, not in commercial practice. The main elevated metabolites in case of enteric fever are ethanolamine, glycuronic acid, phenylalanine, pipiculic acid, and mono and oligosaccharides. The management has an historic perspective. The enteric fever exists from a long back time. In the pre-2000s era, where there was very less drug resistance, chloramphenicol was the first line drug. 50 to 100 milligram per kg per day was used. It was effective but declined in use because of the major issue of bone marrow suppression and high relapse rate of enteric fever. So in the past, ampicillin, amoxicillin, cotrimoxazole were also being used. So in the modern era of MDR and fluoroquinolones resistance, with the rise of MDR, Salmonella typhi and Paratyphi, it's necessitated the shift to newer drugs. The fluoroquinolones era became the treatment of choice in the early 2000s. Ciprofloxacin 500 mg DD and Influxacin 400 mg IVQs 12th hourly were used in the past. Nowadays, resistance is also widespread, especially in the South Asia, where GYRA gene and GYRB and PARC, PARE, all these chromosomal mutations lead to quinolone resistance, also called the quinolone resistance determining region mutations. These led to the development of resistance to ciprofloxacin and ofloxacin and other fluoroquinolones in the treatment of enteric fever. So these are called MDR salmonella. So now there is a rapid shift to the third generation cephalosporins, of which, because of rising fluoroquinolone resistance and MDR strains, the first line therapy nowadays for enteric fever is ceftriaxone. This is a third generation cephalosporin. It can be given up to 14 days. The usual dose of ceftriaxone is 2 grams IV OD once daily, can go up to 2 grams IV BD or weight based. In case of an oral drug, when you want to discharge the patient as OPD basis and can able to tolerate orals, can able to tolerate the fever with paracetamol, can discharge the patient with Cefixim, that is 400 milligram per day uh, for 7 to 14 days. It is effective for MDR strains. It is widely used in severe cases. There is an emerging alternative such as azithromycin. When the Salmonella bacilli is even resistant to ceftriaxone or Cefixim, we can use azithromycin for XDR strains. It has a very good oral bioavailability, now widely used where quinolone resistance is existing. So the usual dose is 1 gram on the day 1, followed by 500 milligram per day for up to 5 to 6 days. So XDR Salmonella is extensively drug resistant. It is majorly resistant to third generation cephalosporins and all other previous generation drugs such as fluoroquinolones, cotrimoxazole, chloramphenicol, ampicillin. So for these kinds of extensive drug resistant salmonella, you can use carbapenem such as meropenem in severe cases, and in few rare cases where carbapenems are not available or contraindicated. In the such cases, you can also use tigecycline. And one interesting scenario is fosfomycin. Fosfomycin can also be used for treatment of enteric fever. The Pakistan reported around more than 300 confirmed XTR cases in the 2016 to 2020 period. So treatment modalities as a general summary, in the 2000s era, it was chloramphenicol, amoxicillin, cotrimoxazole, then followed by fluoroquinolones and third generation cephalosporin. Now it is a paradigm shift to current generation where third generation cephalosporin such as ceftriaxone, cefixime are the first line, and then azithromycin can be used as an alternative. Second line are carbapenems such as meropenem, then tigecycline and fosfomycin. So prevention and vaccination, it is a major public health issue. So vaccines are available. Once a patient recovers from typhoid fever, try to administer a typhoid vaccine. Or in low socioeconomic settings, or patients with frequent travelers, outside food intake, uh, in unhygienic setups, frequent travelers, you can always use a vaccine. Vaccine is available in VI polysaccharide vaccine or TY21A oral vaccine. There is also availability of conjugate vaccine by type bar TCV. It is long-lasting immunity suitable for routine immunizations and useful for outbreaks. So always encourage improved sanitation and sewage management, safe food handling, hand washing, and increased vaccine coverage. So finally, as a conclusion, the enteric fever typhoid is a major health issue in developing nations. There is a shift from clinical diagnosis culture, then now rapid diagnosis is coming up with typhoid at IgM. Yet the blood culture remains the gold standard despite sensitivity limits. The therapeutic strategy, antibiotic resistance has reshaped the treatment. Therapy depends on the local resistance pattern, drug availability, and safety. The key is improved diagnostic stewardship and vaccination can help eradicate enteric fever completely. Thank you for watching. Hope you learned something on enteric fever. With the next video, we'll continue this infectious disease series. This is Medicine Beyond Harrison's. Thank you.